Okay, everyone, thank you. Can I bring everyone to this meeting? Okay, thank you, everyone. Thanks for joining and welcome to those people watching online. My name is Andrew Scopes. I'm the councillor for the Beeston Holbert ward and I'm the chair of this meeting. Just to remind everyone, this meeting is being recorded and webcast live on YouTube, and you can find it again by searching for Leeds City Council, and it's one of the options. For the benefit of the public and people watching in the future, we'll start by doing introductions of board members. We'll start with board members, and then when we get to the relevant items, we'll introduce guests, if that's okay. So with that, I'll ask, going to my left, please. Don't forget to keep the microphone a bit closer to you if possible. Thank you.
Good afternoon, everyone. I'm Councillor Kevin Ritchie, Bramley and Stanley Ward. And can I just welcome a constituent of mine, young Dominic, who's a student at Notre Dame College studying politics as one of his A-levels, and he's interested in our local democracy work. So hope you enjoy the meeting, Dominic.
Good afternoon, everybody. Councillor Bromley representing Horsforth and Rawdon, and welcome, Dominic.
Councillor James Gibson, representing Crossgates and Winmore Ward.
Councillor Taylor, representing Chapel Allerton Ward.
Councillor Holroyd, Ardsley and Robin Hood Ward.
Councillor Mahaley France Meir, representing Moortown, and welcome to the students that have come in today.
Hi, Hannah Sauberts, Head of Health Protection, deputising for Victoria Reeton, Director of Public Health.
Thank you. I'm just going to start with the members and then I'll come to guests if that's all right. Thank you. Okay.
Hello, I'm Jonathan Phillips. I'm co-chair of Health Watch Leeds and I'm a co-opted member on this panel.
Good afternoon. I'm Councillor David Blackburn, Farnley and Wortley Ward.
Good afternoon. I'm Councillor Lynn Buckley, representing Holwoodley Ward.
Good afternoon, everybody. I'm Councillor Caroline Anderson. I represent Adlon Wharfdale Ward.
Good afternoon. I'm Angela Brogden, the Principal Scrutiny Advisor to the board.
Super. Thank you very much, everyone, and welcome. Okay, we're going to start by going through the usual sort of procedural items at the start of the pack. So I'll pass to Angela to go through those. Thank you.
Thank you, Chair. So in relation to item 1, there are no appeals against the refusal of inspection of documents. Under item 2, there are no items for exclusion of the public. Under item 3, there are no late items. And under item 4, at this point, please may I ask members to declare any interests in accordance with the Council's Code of Conduct. And I'll take silence as none. Thank you. And in relation to item 5, Chair, we do have apologies from Councillor Lay. Thank you.
Super. Thanks very much for that. Okay. Moving on to the minutes. I'll first take points of accuracy. Are there any matters of accuracy anyone wants to raise on the minutes from last time? And that's a no. Okay. Thanks. So matters arising. I'll start with you, Angela, and then I'll bring in board members. Thank you. No matters arising. Super. Any matters arising from members that want to right? No. Okay, great. Okay, so with that, we're going to move on to the first substantive item. So that's, I think it should be starting page 13 of our packs. And so what we'll do is we'll start by introducing our guests who are here for the healthcare workforce planning in Leeds. And then once everyone's introduced themselves, I think I'll ask Kate to make some opening remarks. So over to you. Thank you.
Let's try again. Hannah Sauberts, Head of Public Health Protection, deputising for Victoria Reeton, Director of Public Health.
Hi, my name's Lindsay Bell. I'm one of the senior managers in the primary care team at NHS West Yorkshire ICB and programme lead for vaccinations.
Hi there, I'm Helen Smith. I'm a programme director at the ICB in Leeds, leading on same-day response urgent and intermediate care, and here to present the Winter Resilience paper today.
Alison Kenyon, Deputy Director of Service Development with Leeds and York Partnership Trust, representing Sarah Munro.
Hello, I'm Sam Prince. I'm Director of Operations and Deputy Chief Executive at Leeds Community Healthcare.
Hello, I'm Kate O'Connell. I'm Director of the Leeds Health and Care Academy and here to present the item on workforce.
Can I just ask people just to move their microphones a little bit closer, because some of us up here are a little bit hard of hearing. Thank you.
Hello, Darren Skinner, Director of People and Organisational Development at Leeds and York Partnership Trust, supporting the Leeds Health Care Academy.
Hello, I'm Shona McFarlane. I'm the Deputy Director for Adults and Health, Leeds City Council.
Good afternoon, everybody. I'm Caroline Barrier. I'm the Director for Adults and Health at Leeds City Council.
So welcome everyone. Thanks for coming today. I appreciate you taking the time out to come and speak to us. And with that, I'll pass over to Kate. So you can assume we've read the report, but is there anything specific you want to draw out? Please feel free to. Thank you.
Thank you. So it's been a year since we have been to this committee to discuss the approaches to collaborative workforce in Leeds. There have been some substantive policy shifts over the last 12 months. So I think a lot of our focus has been understanding how they impact on Leeds and trying to predict and plan for some of the activities that we're going to need to take over the coming years, not least the 10-year health plan for England, but also the substantive changes in NHS England and the ICB as well, which has created some uncertainty, I think it's fair to say, across the system. But what positives in terms of Leeds is still a pivotal part of the health mission for the government, and the work with the Department of Health and Social Care based in Quarry House means that we're in a good position to try and preempt some of those challenges and be working with partners to try and work our way in how we translate that policy into practice that actually impacts on our local communities in a positive way. That's not to say there haven't been substantial financial challenges and operational challenges across providers over the last year, and they are set to continue in the current circumstances. And of course, there is quite a lot of scrutiny, and rightly so, around the services that our providers are able to provide under that increasing pressure from a financial and operational perspective. The long-term indicators that we look at collectively mean that we've got a focus over that kind of 5 to 10 year horizon. Unfortunately, we haven't had much clarity around apprenticeships over the next 5 to 10 years. We were waiting for some policy changes around that, and obviously in Leeds, apprenticeships have been a big part of our approach to bringing employment into the health and social care sector. However, you'll see from the indicators that numbers and engagement in apprenticeships has remained stable, which I think is a positive at the moment. And there's been a substantive increase in collaborative learning and reach across different partners beyond statutory partners into primary care, community care, VCSE organisations who are all contributing to health and social care workforce. So I've said in the paper around the levels of risk. I think when you look at the aggregate position, our health and care workforce in the city is reasonably stable. That's not to say it's all positive. There are definitely pressures in terms of capacity, and there are peaks and troughs when you look at individual providers and services in the city. We know that there are pockets of higher turnover, particularly relating to contract insecurity in various areas. And there are still wellbeing challenges which are leading to high levels of absence in some services as well. But you'll see from there, the last annual review, that there's been a lot of collaborative interventions to try and support our workforce through that, through those challenges. Particularly want to highlight the work with children and young people, because that's been a significant focus for this last year and has made some real great impact, particularly in community centres and schools, engaging with over 6,000 children and young people over the last year to look at how potential future careers in health and social care link to their current health and well-being and that of their families, which is really great. And I also want to highlight the Health and Growth Accelerator work, which is part of the government's national initiatives that West Yorkshire is part of, And the work in Leeds has been particularly focused around thriving at work and helping people who are potentially at risk of becoming economically inactive, i.e. leaving the health and social care workforce altogether. How we help them stay and thrive in work. And that is showing some really positive outcomes, both in terms of numbers of engagement and outcomes, but also the people's experiences and human stories that are coming through that work. So looking to the future, I think there's a really clear focus from the 10-year health plan around the integrated neighbourhood health. And as I said, Leeds is very well positioned to be part of that. And from a workforce perspective, we've got a good partnership established to try and drive that work forward in the interests of residents of Leeds. And we are taking a long-term view of that despite short-term project funding. So we have the infrastructure through the Academy and the established partnership, which means that we're able to build on that work year on year and adapt it into what we do for business as usual. So I'll stop there, but happy to take questions.
Thank you very much. So members, if you want to ask questions, indicate in the usual way. Just to get started, I've just got a couple of initial questions. So one is around, has there been any sort of change in your strategy around the idea of shifting from to prevention? So is that different skills, or is there something you need to change in that? And then the second question, in terms of vacancies and bank and locums, have we been able to see any? Do we have any data on whether that's reducing? Thank you.
Yes, so I can certainly take the first question around prevention. So I think that's been an ongoing trend over the last few years. There's been a clear strategic imperative to try and develop skills in that prevention agenda. I would say probably over the last 2 years or so, there's been much greater partnership working around the public health space, and that prevention work that's then feeding through into the broader health and social care workforce. Obviously, the role of VCSE is really important in that as well, because of their links in with communities and their ability to work with communities and individuals to approach some of those health promotion aspects as well. So we're seeing some really positive increases through the training that's available for health and social care workforce. And since we have started that expansion programme, we've seen a big uptake in the training of skills and knowledge around prevention, but still a lot more to do. In relation to the agency, I'll ask Darren to come in a moment from an NHS provider perspective. We don't have any issues in terms of actually filling vacancies generally. So we can either fill them through bank or through agency. So the skills pool is out there generally for the services that we need. I think there's been a very clear direction to try and reduce cost in relation to using agency. And obviously, one of the ways in doing that is encouraging people to join organisational bank. So we're trying to track and understand the implications of that. A lot of the people who are on our organisational banks are also employed elsewhere in the system, so it's not usually a standalone contract. But yeah, there's still a pressure through agency spend. But I'll ask Darren to come in a little bit more from an NHS perspective.
Yes, so in terms of the NHS, and I can only speak for my organisation, we have seen a significant reduction in the usage of agency and bank usage, and an increase in bank usage. So there is a directive from NHS England for all NHS organisations to reduce their agency usage by 30% and their bank usage by 10%. As an organisation, we've been really successful in transferring a lot of our agency workers onto our internal bank, which provides significantly more benefits for them. However, that's caused an increase in the usage of bank. So we are undertaking a significant piece of work on how we can reduce our usage of bank nursing. And actually, we've got a significant programme, particularly around healthcare support workers, of transitioning them into substantive employment. So that's been quite successful.
Yeah, super. Thanks for that. I just think there's something about getting people through the qualifications and into permanent contracts, which is almost certainly cheaper than even the bank stuff. Great, thank you. Okay, I'm going to bring in Jonathan.
Thank you, Chair. I just wanted to explore a bit. On page 21, there's a diagram that shows the health and care workforce profile, where roughly a third of the workforce is adult social care. But when you look on page 24 at the take-up workforce engaged in academy learning, etc., it seems the proportion of involved in social care is much, much smaller. And I wonder if you could explain that, because in a way it sort of feels like it's mainly health and only a little bit social care.
Yeah, so this is an ongoing trend and something that we're trying to work on collaboratively. I think the key issue is that obviously through our social care employers, there are hundreds of different social care employers that employ very small numbers of staff. So in terms of engagement and being able to release those staff to participate in training, even to access online training, being aware of these particular offers that are open to them, is a bit of a challenge, to be honest. So we work through our social care networks in the system. Caroline and her team are obviously instrumental from a council perspective in engaging with the independent social care employers. We work with Leeds Care Association and Skills for Care to try and really promote access to this training and encourage uptake. But we are aware of some of the real challenges of both awareness of people being able to access it and the practicalities of people taking time out of working in independent care organisations to participate, particularly in the face-to-face training, which is a challenge. So yeah, it's something that we're determined to increase, but that's the explanation of it.
Thank you. Have you got a separate follow-up? No, great. Okay, Councillor Ritchie.
Thank you, Chair, and thank you for the report. I've got a few things. First of all, on page 18, it mentions staff morale is relatively stable. Could you just give us some indication how you've got that information together? Because I'm certainly conscious that, sure we all are, as cuts start to bite, people are being asked to do more pressures on people, perhaps their terms and conditions might be at risk, which generally undermines staff morale. So I'd be interested in what evidence you've got to reassure us of that fact that you state there. My second question is around, there's a reference to the new visa legislation. Now, my understanding is the government have raised the salary threshold, which in an ideal world that our care workers would be receiving that salary, but that's unlikely to happen in the short term. So could you just expand on how you think that will impact recruitment going forwards? And then the final thing, Councillor Scopes mentioned banks, obviously to reduce agency costs. Obviously, you mentioned the NHS have their own bank, and some other third sector organisations, large ones, have their own internal banks. Is there any workaround or scope for a sort of citywide bank so that smaller providers may be able to utilise staff from, a bank, citywide bank, to reduce their own costs on agency? Thank you.
Yeah, thank you. So I'll start with the morale question. I think this is a really kind of broad indicator. So I would say there's absolutely pockets in the system where there is much more kind of tension and different trends in terms of morale. The indicators we use are usually through staff surveys, so they're usually taken at one point in time during the year, so are not necessarily particularly susceptible to fluctuations that have been immediate. And of course, we're talking about views across the kind of 60,000 wide workforce. What we're looking at from a city perspective is if there's any kind of significant trends in that we can track since the last time we assessed it, and we take professional insights from the HR director colleagues across the city. So, and what I would say is that the morale in the workforce hasn't been high for a long time. So whilst I say it's stable in this report, it's not necessarily high and stable. It is just not, there's nothing significantly disruptive around it at the moment. I think we are expecting it to be even more challenged over the next year or so. So we're seeing that kind of uncertainty, particularly in contractual situations and the pressures. So, you know, we expect that will flow through to morale, but we are trying collectively and as individual employers to tackle that. The point around visas, I'll bring Caroline in a moment. She may have a perspective on this. I think it's very complex in terms of how we manage that collectively in the city, because, as I mentioned before, lots of the people affected are individual independent employers, and looking at how that impacts on their specific workforce is quite different. I think the challenges around fair pay and all of the associated aspects of that is something that in Leeds we've been really kind of prioritising for some time now, and we've been involved in the West Yorkshire Fair Work Charter and trying to drive that through the health and social care sector, and the work with the Health and Growth Accelerator as well, to really understand that value of good work, not just any work, but good employment, and the impact on health and vice versa. So I think the work that will help shore up the risks around the visas is carrying on anyway, but I think there is absolutely a gap, and we will see, and we are seeing some of the challenges of the visa regulations and the thresholds changing, creating some real pressures in the system. Caroline, I don't know if you want to come in.
Thank you very much. Yes, we are anticipating, and we're already hearing from some providers, particularly residential and nursing care providers, saying that they're worried about the changes and the impact, in that they will not be able to go overseas recruitment in the way that they have done for the last couple of years, where it has really eased pressure around workforce capacity. This is not always sort of, you know, one side to this. There's another side to this as well. What we have seen for home care particularly is quite a lot of adverse impact of the international recruitment, where we've seen so many displaced workers. So they've been brought in by the less scrupulous of providers. They've been brought in with the promise of sufficient work, enough hours of work per week, which then allows them to meet their visa conditions, but then that work hasn't been made available. And so we've had thousands in the region of displaced workers in Yorkshire and Humber. We are working with providers, with other providers, the more you know, high caliber providers, to try and find alternatives for these displaced members of staff. So it's almost a sort of, you know, there is a real negative impact as a result of the changes in the visa rules, but equally there's a little bit of sort of opportunity to make sure that we're securing and matching those displaced workers where there might well be vacancies in other areas. So we're balancing that. Longer term, to be quite honest, we don't know the impact. Obviously, we're expecting changes to happen as a result of the fair pay agreement, which hopefully, when it comes into effect in 2028, will really help with us being able to source enough workforce capacity within locally and within this country. But of course, that in itself is challenging, because we need to make sure that there will be appropriate levels of funding, which we can then pass on to providers to pay their staff, you know, above national living wage. So all of these things come with complexity, but hopefully working towards a positive outcome going forward. But it's challenging, without a doubt. It's challenging.
And then, yeah, just to pick up on the last question around the bank. So it's a consideration that we've discussed previously in the city around whether there's an opportunity to collaborate more around a kind of citywide bank. And certainly we've been looking at what other places are doing to try and tackle this. I think there's a lot of complexity in it and risk, which, you know, in a stable environment is one thing, but in the current environment is quite challenging to work through from an organisational accountability perspective. So there's a lot of issues around indemnity and risk, and as I mentioned before, what we understand about our workforce is that the majority of people who work on the bank in current form are already employed in the system. So the approach we decided to take was the staff portability agreement. So we set up a couple of years ago now a framework which allows organisations to deploy staff into other organisations for short periods of time to manage emergency or workforce pressures, service pressures. Where it is used, it's used very successfully. I think in the report it references that there is quite limited take-up of it. So I think there's a piece of work for us to review why that is not being used more widely and what some of the challenges are about the pace of being able to deploy somebody in a situation where you need somebody quickly, and the automatic go-to responses, I think, for many private organisations is sadly agency, because that's where their relationships lie. So I think there's a bit of work to do to understand what the options are, what the barriers are. But we do have some mechanisms in Leeds which will help that.
Super, thank you very much. Okay, I'm going to bring in Councillor Gibson next.
Thanks, Chair. I think you've sort of answered the question. I was going to ask a question around morale. Obviously, a lot of change. I mean, there's been, you know, significant pay increases across the board, inflation beating pay increases over the past couple of years. You know, we hear that waiting lists have come down on obviously not the past 3 months, and productivity up. So I would have expected morale in some quarters to have improved, but then again, you know, with the NHS England reorganisation and strikes looming as well. So is it the case when you say it's stable that sort of some parts are happier than they were, and then other parts are less happy, and it's sort of a movable feast? And that maybe you could confirm or deny that. So I read this today, which in the Guardian, which absolutely shocked me, and I wondered whether it's something that we're having to deal with in Leeds. I apologise to people because it is a shocking headline, terrible, but I'm going to read it out anyway because it's probably the grim reality of what's happening on the ground for some people. So the Guardian headline was "Frightened to get out of their cars, Britain's toxic race debates threaten overseas care workers." And the article goes into detail about how some care workers are being advised to go into twos and to not have two black or Asian or overseas care workers together, and always pair up with, I guess, somebody from the UK. Are things that bad? Are we ever experiencing that in Leeds? Is this, you know, I'm not going to get into the politics of it, but, you know, and how are we supporting staff through this? If they're, you know, these are the people that are looking after our most vulnerable and vulnerable citizens, and are doing a wonderful job that is absolutely backbreaking and incredibly skilled and difficult, and they're having to deal with this on a daily basis. I mean, what on earth's going on, and how we're supporting them?
Thank you very much. Thank you, Councillor Gibson. We absolutely share those concerns. This isn't new, to be honest. We know that from our care providers, but again, particularly home care providers, and I'll just talk about social care. I mean, there will be the same, I'm sure, in the NHS as well. But we know from our home care providers that, you know, many of their care workers have been turned away by people and said, no, I don't want you to come and undertake, come into my home or undertake personal care. And so this is something that our home care providers have been working with for a long, long time. If we go back 10, 15, 20 years ago, many people were saying, no, I don't want a male carer coming in. I only want female carers. So our care providers are quite used to people turning people away. We have a very clear position that, if it's reasonable request, then in terms of, language barrier or difficulty understanding a care worker, then we will make sure that the provider does organise rotas so that if it's double up, etc., appropriate staff can go in, particularly to meet the communication needs of the individual. And it could go the other way as well. It could be, an ethnically diverse person requiring a service and a white carer going in and not understanding each other. So really having those sensitivities is really important. The more recent concerns around the care workers going in areas where they think they might experience racial abuse and discrimination, we very clearly say zero tolerance around racial abuse, and we will stand by providers and their care workers if they say we can't deliver a service to this individual because they're being abusive. And it doesn't matter if it's to a white member of staff or if it's a member of staff of ethnically diverse background. We will not tolerate racial discrimination in any way. It could be Polish, it could be Ukrainian, it could be anybody experiencing that, and that is just not acceptable. And our social work staff will in turn, and our commissioning staff, contracting staff will in turn talk to the individuals and their families to say, if you want this care, you've got to make sure that you're not getting, the care workers are not getting abused. In terms of wider community, people going and driving in areas, so not necessarily the experience that they get when they go into an individual's home and the person receiving the care, but if it's the wider community, again, we've got to make sure that providers do provide security for their care workers so that they do take into consideration and they don't place their care workers in potentially difficult situations. So the pairing up, having access to phone and being able to be on call, because we're talking about evenings, we're talking about weekends when there might not be office staff available. So having an overall well-being and support offer to any care workers, and if care workers are saying I'm really frightened to go in that area, then that their wishes should be absolutely taken into consideration. Fortunately, at this point, we haven't had home care providers coming to us saying that their care workers are scared about going into particular areas in more recent times. We do, and we will continue to check in with providers to say we need to know if this becomes an issue, but we haven't heard that so far.
I'm going to bring in Darren. Did you want to comment? And then I'm going to bring in Councillor Venner. But I do think it's a shocking situation. It sounds like it's less bad in Leeds, but it's still deeply worrying. But I'll let Darren and Councillor Venner comment.
Yes, thank you. Sadly, we're hearing those stories within our own organisation, and it's where our colleagues from the global majority are going about their day-to-day business in their normal life, and they're bringing some of their experiences into work, which is quite, we've heard some really distressing stories. So we are actually, we've put on a number of what we've called listening sessions to enable people to come to us and tell us what their experiences are, and working with them in order to try and overcome and prevent some of the issues that they are seeing on a day-to-day basis. But yeah, sadly, those headlines are real.
Thank you. I wanted to follow on from this point as well. So on the Health and Wellbeing Board, we've been talking for quite a long time about the abuse of staff in health and care settings, and we've done some really specific workshops just looking at that issue, like what staff are facing, how we protect them, how we support them in increasingly challenging work environments. Where that came from was I'm a governor at LYPFT, and I was quite shocked a couple of years ago by the percentage of staff that had faced abuse from patients or their families or the community. But I don't think that's a specific LYPFT thing. We know as councillors, we live in an increasingly intolerant society. You know, the amount of abuse we get has increased, you know, since COVID, since, you know, the cost of living crisis. It feels like a lot of people are at the end of their tether and are increasingly offensive in anyone in a public facing role. So that's where kind of I started sort of wanting us to look at this as a health and wellbeing board. And then following the disturbances last summer in Leeds and then the riots elsewhere in the country, we looked at this specifically on the health and wellbeing board because of the impact on people of what was happening and the beginning of the kind of rise in racism and far right activity that we're seeing now. And one of the things that I think is a challenge in care environments is people's right to care, even if they're really offensive. So this is a bit of an extreme example, and obviously this doesn't apply at all to everyone who's under the care of the Mental Health Act, but staff working in wards with people who are sectioned under the Mental Health Act can't not work with them if they're offensive. Well, individuals can. I think that's the point. Like, people have a right to care and may in that circumstance be being offensive because they don't want to be there and or because they're unwell but still need to be cared for. So in that circumstance, it's very much about how we respond as employers across the city, how we support staff that are particularly affected, as Darren said, particularly staff from the global majority, how teams, you know, configure their work so that staff that are particularly affected are not consistently on the receiving end of abusive interactions from people. The police also, their hate crime coordinator, who's called Sergeant Marine something, I can't remember her second name, she's done some specific work about hate crime in the NHS, where she's actually gone on to wards and worked with staff where people are under the care of the NHS but actually, you know, behaving in a hateful way. So I do think it's a particular challenge for staff working in caring environments, because people have a if someone has a need for care, they have a need for care. But it's about how we support those staff and you know, ensure that they're not on the receiving end of abuse as part of their daily work. But it is an ongoing challenge, but it's an ongoing challenge we're really alive to on the Health and Wellbeing Board at that strategic senior level. After last summer with the riots, we had a session where a representative from all the organisations, so like Children's Social Care, Adult Social Care, LTHT, LYPFT and LCH, they all gave a summary of what they're doing to support staff, because it felt really important that we know some staff are particularly affected by what's happening, and what are we doing to support them in their work? Because in any public facing role, of course, the NHS or social care is a microcosm of society. So if there's racism in society, it's going to be in our organisations, and we have a duty as employers to look at how we support people working in those settings. Thank you.
Thank you for those comments, Councillor Benner. Can we bring in Councillor France Meir?
Thank you, Chair. Thank you, Chair. I just want to go back to NHS staff morale. Staff morale would be quite poor if policies are used to weaponise against staff, to coerce staff to do to change their annual leave or to do certain roles. That's not part of their job that's not part of their job description. So what are you doing to tackle that, so that staff members are able to go to work and feel that, do you know what, we enjoy the work that we do without being pressurised or coerced to doing something that we don't want to do. And I also want to say thank you for using the correct term, global majority, as well. It's good to hear it. It's been going around for nearly 10 years, and for some strange reason, we're not using it. I worked at the NHS about 25 years ago. I know one of my colleagues was a nurse many, many years. No, I shouldn't have said that. I shouldn't have said that at all. And people were refusing help then because of the colour of your skin. But I'm concerned about the morale and the coercive persuasion and the weaponising of NHS policies against staff members.
So thank you for your question. In terms of my organisation, I'm not aware of any of our policies being used as a weapon. However, we have got very robust grievance procedures, which our staff use on a regular basis. But that particular issue has never been raised in my organisation. But we have numbers of listening sessions. We have a number of staff networks where I'm more than happy to go back and raise that with people to see if there is a problem. In terms of staff morale, Kate was right. We have an annual staff survey, which is probably the biggest global staff survey that there is in the NHS, and it is currently running right at this moment. So it launched at the beginning of October. And we use that as a barometer, but sadly it's a once a year process. But we do what we call regular pulse surveys throughout the year, although there's very little uptake of those surveys, sadly. But the other way we test and morale within the organisation is through our staff networks, listening to our staff and what they're telling us, and we are quite responsive where we can be. There are a number of issues that we are still working on, and there's a lot to do, but it's something we are constantly aware of, because it's we need to keep our staff, so retention is very key in the NHS at the moment, and we're doing a significant amount of work around retention.
Yeah, so if I could come in on that point as well, because I think you raise a really valid point, and it's not restricted to the NHS either. It definitely applies across all employers. And I think one of the big challenges we see at the moment is this tension between the drive for productivity and trying to get the best out of very finite resources for the benefits of the patients and service users, and making sure that the staff are well looked after, supported and thriving at work. And I think some of the collaborative interventions that we do across Leeds are really powerful in actually challenging some of the perceptions and misconceptions perhaps about that tension and how that plays out in the real world. So we've had some really great examples of where smaller organisations can be much more flexible, for example, in terms of their contracts, the ways, hours of working, things like that. But they're perhaps not as good at providing some of the health and wellbeing additional employee assistance programmes. So it's about how do we bring the best of each different employer from their different setting together and try and open up that access and share that learning across the employers so that they can actually come together and try and improve things from the different perspectives. One of the things we've seen around the Thrive at Work, which is the Health and Growth Accelerator, is exactly that tension coming into play, because what we're trying to do through that is help retain people in the workforce because they've got skills, they've got passion, they've got talent, and the only reason that they're potentially thinking about leaving is due to their health. So how do we support their health and well-being to help them stay in work? However, you've got policies and financial pressures and all of those other things which are playing into that space to say, actually, is it time for me to move on? Do I need to I need to think about myself, actually, the experience of, whether anything we've talked about today, some of the operational pressures, that job might not be right for that person anymore. And I think there is always that individuality there that we've got to try and take care of. But I think the point I would make is that by working together and sharing insights and assets across the organisations in Leeds, we've got a better chance of trying to support the individuals who can access those benefits.
Thanks for that. I feel like there might be a specific issue that you're aware of, Councillor France-Meyer, but may not be the right forum to discuss it in. So if there's a specific issue, I'd encourage you to write to me and Angela, and then we'll engage with Darren about that item, and we might be able to find the resolution, because it does feel like I think it's this specific question. Okay, I'm going to bring in Councillor Bromley next.
Thank you. Really interesting conversation and helpful so far. I just wanted to bring back to the point that you was mentioning on racial situations that are occurring. Do we have any sense of responsibility in cracking down on misinformation, disinformation that will be consumed by people more likely to be isolated? Out and about, if I based everything on the community of what I saw online or was fed through particular channels, I would feel like everything was really great and everybody's opinion was the same. But once I get out and about and start talking to people, you have a realization that things aren't quite as dire, but also a sense that people do are able to communicate and form a community together. But if you are isolated, you'd be more likely to believe the things that are fed. Is there a sense that might be a responsibility of ours that we could provide along with care, or is this something that has been discussed before?
So I can certainly pick up a bit of that. I don't know if colleagues from Council and NHS want to jump in as well. So I think we absolutely recognise that as employers, everybody in the city's got a responsibility to try and make sure that they're challenging any misinformation, miscommunication, and trying to create an environment where people are able to have open conversations and to question and to challenge. So we put on collectively, we do a lot of training around how to have difficult conversations, how to be an active bystander, how to create an open, psychologically safe culture where you can have some of those difficult debates and discussions and question and challenge some of the things that you hear or see or etc. I think it is such a kind of pervasive issue across communities that it's not something that employers are going to be able to solve by themselves. So I think there is absolutely working with our VCSE colleagues in the community sector, working with community groups. Darren's referenced networks that we've got across the system who have got really good contacts and insights into what's happening. We also actually work with our universities and research partners to understand what's happening elsewhere in the world. You know, Leeds is not a completely unique place, which we often think it is, but it's what can we learn from other cities who have actively tackled some of this stuff, which is, you know, it's global, isn't it? You see it in every country in one way or another. So I think we recognise that we've got a responsibility to look out and try and connect some of that learning back into how we play things in Leeds, and it's not just one. It's not going to be resolved by just one sector or one employer. It's going to have to be all of our responsibilities.
I was also thinking it's not just deliberate disinformation, well, it does tie into that, but also AI videos and anything that could be exposed to. It almost seems that we should have an element of care to people, that this is an important aspect that they could be exposed to, and how are we implementing a care around that along with physical care, if that makes sense.
So, I mean, I'll ask colleagues to come in if relevant, but certainly from where I sit across the partnership, I see a lot of our accountable officers and chief executive officers actively stepping into that communication space. So if something has gone viral or there's been something in the media, they will proactively make a statement about it, sending out communications to staff to clarify what the position is. And that happens a lot because often what happens in health and social care is subject to either social media or media attention. So I think there is quite a lot of proactive communication across to members of the workforce around clarifying things. And And there's quite a lot of open sessions as well with senior officers where staff can ask questions and get into discussions with them. And I know that there's certainly ways in which people can contact senior officers to clarify things. So if they've seen or heard something that they're not sure about, they're encouraged to do that. But yeah, there's always more that we can do.
Yeah, thanks for that. And I think there's a responsibility in all of us, isn't there, to call out misinformation or lies, as we used to call them. Okay, I'm going to bring in Councillor Taylor.
Thanks, Chair. I'm not going to prolong with this because the report is absolutely brilliant. But let me go back against the racism and what's in the workplace. I was the quality lead for numbers of years, and I have staff from the NHS, the council, the schools, from the BAME community, other communities. I'm not going to go all into impact, but can I just ask one question? It's the people around the table that makes a difference when you're having these conversations. I can speak for you, but when you have different culture that understand culture, you will have a better conversation. Don't want to go further, but listen to what you're saying. You are trying, but you are only halfway there if you don't have everyone around the table. And what I'm seeing and witnessing is going back to the 60s, 50s, when my dad just came to England and many others. And we need a conversation. We have more equality, so get everyone around the table who understand the individuals. Thank you.
Thank you. I think that's probably a comment. Thank you, Councillor Taylor. Okay, I can't see anyone else indicating. So just go back to what our recommendations were, to consider the report and talk about it, basically, which we've done. I'd just like to thank you for coming today. I think there's a real and thank Councillor Gibbs in particular for bringing up the issue he did, because I think it is really important and something we need to reflect on, probably more than we have done, because I think sometimes it's those implications of the wider context that we don't see day to day, and particularly low paid carers who are doing a job that is really hard and very skilled, as you said, Councillor Gibson, undervalued in my view, getting the brunt of some of the stick. So I think that's something worth reflecting on. Okay, so I'm going to move us on now to item 8. So that's page 27 of your packs. I think Helen is going to introduce this paper. So over to you, Helen.
Thank you, Councillor Scopes. Thank you, everyone. I'm here today to share the contents of the paper on our preparedness for winter resilience in the Leeds Health and Care Partnership. And obviously you've all had sight of the paper, but just to pull out a few key points is that this is a winter resilience plan with an overview of the system, but organisations do have more detailed individual plans, but it does pull together in terms of where we're working collaboratively and as partners to prepare ourselves for what we expect will be winter surges. It is written partly in the context of the Urgent and Emergency Care Plan, which was an additional document published in June 25, and that detailed 7 key metrics for us, which we will be measured against in terms of performance. Some of those are where we've already been benchmarking against, and some of those provide added overview on particular areas. So we have taken that into context in terms of what we needed to mobilise additionally for winter. Heightened winter pressures are to be expected, and we usually model ourselves on what's happening in the southern hemisphere in the previous 6 months, and the modelling tells us that we are largely to expect a winter similar to last year. So we will see those increases in respiratory illnesses, in flu. Last year we started to see those peaking towards the end of November, and mid-December towards early January was when we really saw those pressures. It was quite long and sustained, so we didn't hit a real sharp peak and then drop off. We slowly increased. We did reach the peak, but then there was quite a long tail off to the winter period. So we are expecting, based on that southern hemisphere predictability, that we will see something similar, and particularly around surges in respiratory illness where individuals are vulnerable to respiratory conditions, taking into account our seasonal changes with the weather and that additional vulnerability. In response to that, we do have a defined oversight and governance structure, so we are well placed and prepared to respond as appropriate. We come together as partners on a very frequent basis and have the ability to escalate with more senior partners depending what we are faced with at any given moment in time in the system. So those plans have been reviewed and are ready to operationalise, and indeed some of them already are. Firstly, we do look at where we can gain traction in terms of prevention, and vaccination is a really key response to us for that, particularly with the flu vaccination. Although we are also running a COVID vaccination running alongside for those who meet specific criteria. COVID is no longer considered a seasonal illness because we are seeing it all year, although we will see slight variations given those who are particularly vulnerable to COVID infections. But we have started the vaccination for flu, and for children that started in September, and for adults that's in October. And that can have huge impacts in terms of that demand that we see, and vaccinating within communities and limiting that transmission and spread of the flu virus, which for many can result in those attendances at hospital and emergency admissions that we would like to avoid. Alongside that, our public health colleagues work up a winter prevention plan, and lots of initiatives there to try and support people, particularly vulnerable, addressing loneliness, staying warm at home, etc., and supporting people to live well in their communities over these winter periods. As I mentioned earlier, provider colleagues do have more defined plans, but particularly responding to what we expect are additional pressures within our primary acute community and mental health services, and where we might be able to maximise capacity as much as possible and provide flex when we anticipate those surges will come in. And there's further details on those within the paper, and colleagues have joined me today if there's any specific questions around that. Largely, we need to remain efficient around hospital discharges, so accepting that for some people hospital is the right setting for them to go for treatment, but what we need to do is treat them efficiently and facilitate a discharge in a timely and appropriate manner for them to get back hopefully to their usual place of residence, be that home or be that back to a care home that they might have come from. And lots of targeted work going on to make sure that partners work collaboratively together to facilitate those discharges as easily as possible. And in response to that, we have through funding with the Integrated Care Board, we have funded and will be mobilising some additional services that we think will have the greatest impact. So, for example, we've already mobilised in September our community paediatric respiratory hub, so that's a primary care provision to enable primary care to divert children with respiratory infections into a primary care provision, hopefully enabling some of those individuals to stay outside of a hospital setting and certainly keep the capacity in the hospital setting for those who genuinely need it. That there is additional staffing being mobilised, particularly across health and within social care, to provide additional social work availability, which again potentially keeps us on track for completing assessments in a timely manner and enabling people to have their discharge facilitated as quickly as possible. The paper goes on to provide a summary of what we see are the key risks and the mitigations that we've mobilised against those or will mobilise. But I think in summary, it highlights that we are in a strong but challenging position, notwithstanding all of the other external factors that are impacting health and social care at the moment, but entering in a strongest position as possible. Thank you.
Thank you very much for that. Appreciate that. So members, if you wanted to ask questions, indicate in the usual way. I'm going to just start with a couple of questions. That's okay. So the first one's page 49 and 50. So the vaccine take-up rates, which a lot of the numbers are really low, and I understand it's flu rather than maybe a normal immunisation. But I think that is concern, and just appreciate your comments on what do you think is driving that. I think that'd be really helpful. And then the other question I had was on page 48. It looks like for a lot of the periods, there's more people in than the total available beds. So just can you explain how you're managing that? Thank you.
Yep. So the data on page 49 and 50 is the uptake rates from the previous year for 2024-25. The feedback that we get from providers and from patients around the reasons why uptake is low in a particular area are many and varied. It can relate to availability and access to appointments, but we also have challenges around language barriers, cultural barriers, and also dealing with things like misinformation, disinformation, and also trust in authority and kind of statutory bodies. So the reasons can be many and varied, and we do try and work with those providers and also the voluntary and community sector in those areas to try and address some of those reasons through raising awareness, providing information and answering any questions that the members of the community might have around either access or the vaccinations themselves.
And in answer to your next question, with regards to the table provided on or the run chart on page 48, absolutely correct. This is a presentation of the data based on the modelling that we expect, and this is the if we do nothing scenario. So this is the modelling provided by our acute trust colleagues that says, given where we expect demand to be, this is where we would be if we didn't put anything additionally in, and it's the modelling by which we then start to build up our resilience around it. So additionally, on top of this, we have LTHT opening up a number of additional wards and beds across the wards, but that doesn't address all of it. So some of those gains can be had in terms of the efficiency of those discharge processes. So like the additional staff that we talked about, etc., utilising the capacity within our virtual ward, within our community setting, etc. So that there are then a number of mitigations that build against that, which then hopefully brings us back to a level position. Thank you.
Thanks, Helen. That's really helpful. And I think, Lindsay, on your point, it goes back to what Councillor Bromley was saying earlier about us all needing to help with disinformation. I think that's, again, an important thing to note. OK, I'm going to bring in Councillor Blackburn.
Thanks, Chair. First of all, can I congratulate on the report? It's very, very, very thorough. The thing is, this. One thing I'd like to know is, I sit on a body called the Affordable Warmth Partnership, and at our last meeting we were discussing that because of hot weather we've had a surge in summer. Are you finding you are getting that through health service, getting that surge in summer as well as the winter now? That's one thing. The other thing is, I fall into a group. I'm 74, so I don't get a COVID jab this year, which I was very disappointed about. And I wonder, have we got any early indications of the people around about my 65 to 75, if we're getting an increase in COVID amongst that age group? And then finally, we're going to mention something about numbers, about take up and that, but the chair's covered that. But also, when you get to a certain age, which I forget what it is now, is you're entitled to a pneumonia jab, which isn't a yearly jab. But quite honestly, if you're in that older age group or you've got something wrong with you, if you get flu or you get COVID, invariably you get pneumonia straight after. And having that jab protects you. I mean, it protects you for quite a few years. Do we know what the number of people of sort of pensionable age have pneumonia jabs?
Hi, I'll just come to your first point, Councillor Blackburn. I think you're absolutely right in terms of the impacts of heat on admissions and people seeking health appointments. The last time I came to Scrutiny, we were presenting the Heat in the City DPH report, which clearly states that, you know, we are starting to see a change in trends in terms of number of people who need medical assistance during our hottest days. And I think as a system, there's a recognition that at some point, you know, we will need to start having the same plans in place for summer and hot weather and overheating as we do, you know, around winter. You know, there's lots of work going on already, and we, you know, when we look at excess deaths caused by temperature, you know, winter is still where we see our highest number of deaths. However, we are seeing a slight shift in trends in terms of hot weather as well.
And just additionally to add to that, and I don't know if any provider colleagues wish to add, is that we often don't talk about winter surges now. I think we just talk about seasonal surges because winter planning is almost all year round. And the paper does make reference to that governance structure. And it isn't a structure that's just in place there for winter. It is actually utilised all year. And there are occasions, you know, certainly throughout those summer periods where we have those surges in demand, be it because of weather, etc., where we do actually invoke those structures and we do actually, you know, get together as a silver meeting, etc., and have to respond to those particular pressures at that time. So yes, we are seeing it and we are having to mobilise to respond to it. So thank you.
Sam, do you want to come in?
Yes, I think in response to the surges that happen throughout the year, I think it's just worth reflecting on how good the partnership is across the providers, but across health and social care. So that if one partner is feeling the pressure of that surge, people come together to try and work the problem through together.
Thank you. Councillor Bennett, did you want to come in?
Yeah, I was following on. I'm really glad you asked that question, Councillor Blackburn, because as Hannah said, when we were last here, we were presenting the DPH report, and we talked about the fact that we've always had this focus on winter planning, and we need to have the same mentality around planning for heat and thinking about how we work through, you know, neighbourhood networks around that and how we get messages out into our communities. So, Chair, I think this was a suggestion for you, actually. Because it's always been a tradition of this board that there's a session on winter planning. I'd suggest you do a session on summer planning, which is very much taking forward, you know, a recommendation of the DPH report, and it's giving heat the parity it needs to have with cold in recognising it as a health issue, and particularly for as we discussed last month, for certain groups. And also there's a really clear health inequality that it's people living in, you know, the most deprived in city areas, in particular housing, that are most at risk. So yeah, I want to suggest you consider factoring that into your work plan, that you do an actual focus session on planning for summer as a health issue. Thank you.
Thanks, Councillor Bennett. Did you have a follow-up, Councillor Blackburn?
Well, I haven't got the answer about pneumonia. I'll take up on pneumonia gels, which is obviously in report. If you haven't got it, I mean, if you can let us have it afterwards. And then, as I say, early indicators of taking away from younger people, as such, if we call somebody 74 younger, but the COVID jab, have you seen any effect yet?
Yep, so I don't have any details on the impact of not vaccinating younger cohorts around COVID infections at the moment. We've only just started the COVID vaccination campaign, so we'll work with our public health colleagues in Health Security Agency to see if there is any impact. Just on the point around the pneumococcal vaccination, so the uptake of the pneumococcal vaccination is around about 70% each year. And we encourage our providers to take a make any contact count approach, where they can co-administer other vaccinations alongside the flu and COVID vaccination if the patient is happy to have those at the same appointment. So this year, providers are also offering the RSV vaccination, the respiratory syncytial virus, pneumonia, shingles, and flu and COVID is available to patients if they're eligible in those groups as well, to try and protect those patients.
You'd be happy to know I've taken all of them over last year since when I'm entitled to. And I've also got my name down for the first on the list if they come up with an anti-arthritis jab. Thank you.
Thanks, Councillor Blackburn, and Councillor Venner, thank you for your suggestion. I'll take that away and think about it, and if we can squeeze it into the agenda. But I do think you're right that it's a slightly different demographic, but the heat is definitely affecting people, and we saw the graphs last time, particularly Hannah, you used excess deaths or a death spike at those points, so thank you for that. Okay, I'm going to bring in Councillor Anderson next.
Thank you, Chair. I just wanted to ask about the messaging for the vaccines this year, because there seems to be quite a lot of confusion amongst people as to who's entitled and who isn't. And people have been turning up at the doctors expecting a COVID jab and not being able to get one. So what do you think has gone wrong there, and why are under 75s no longer allowed a COVID jab, and frontline health workers as well? Because it does seem, if it's totally down to money, then it's a completely false economy. Because if frontline health workers go off sick and you have to replace them with agency staff, that costs a lot more. So what's the reasoning behind that, please? And also, I read about somebody having a private COVID jab and paying £100 for it. I thought there was no such thing as private COVID jabs. I mean, I've paid for a flu jab myself, but I didn't think you could pay for a COVID jab. Thank you.
Yeah, so I'll try and answer those questions. So the COVID jab was made available privately last year, so you can purchase it. The regulations on who can offer it changed. Just remembering what the other questions were now. The messaging,
Yeah.
yes. So yes, we have had some feedback from patients and providers to say that that has been flagged as a potential issue, that people are not aware that the criteria for COVID vaccinations have changed this year. I think every year we have the national comms campaign begin kind of later than the start of the campaign. People start planning quite early to get their winter vaccinations in some areas. And I think, yes, the messaging should have been better around the changes to the campaign. So we are working on getting some messages out to the public around the changes. The reduction in the eligible cohorts for COVID this year was based on the recommendations of the Joint Vaccination and Immunisation Committee. And I think what they'd found from the evidence is that those groups that were previously vaccinated, so the clinical risk groups and in the younger age cohorts, were not actually at as high risk of severe illness and hospitalisation as some of our older, more vulnerable patients and those in care homes. And so the criteria was adjusted to specifically target those at the most risk of hospitalisation and severe illness and possible death.
Yeah, thanks for that. But it's a really interesting point, Councillor Anderson, because there's something around sickness as well as hospitalisation, particularly around staff who are who'd be off sick even if they're not hospitalised. So I think that's a really interesting point. Hannah, do you want to comment on that, and then you can come back in, Lindsay?
It was just to comment around messaging, actually, and I think our role within the health protection team, within the Public Health Directorate, is to make sure that all of that NHS messaging and eligibility is cascaded through our third sector colleagues and community contacts, making sure that it's, the messaging is in accessible community languages, that there's a really important focus on using our community champions, which is funded through NHS money, to have that sort of trusted voice within communities to be able to answer some of the questions that might be either stopping people from having vaccines or any confusion around changes in eligibility. I know certainly from a public health perspective, we've also funded Leeds Older People's Forum to do lots of targeted work with people this year around those changes in eligibility and to listen to people who may be struggling to access vaccines and look at how they can support them to access those vaccines. So yeah, just to just to emphasise that from a public health perspective, we very much support kind of from a prevention and making sure that information's there. And if it hasn't already happened, there's regular updates that go into the members' fortnightly briefing as well, you know, with just some of the work that we're doing that you can cascade as well.
Yeah, so I was just going to come back in on the staff vaccination element. So we've recognised that that is a significant risk to the system and has been listed as one of our key priorities for this year. So our objective is to try and increase uptake by at least 5% amongst the various staff groups across the city, and working with different providers to make sure that staff have access to vaccination and also are aware of the other places that they can get vaccinated, whether that's their own GP or community pharmacy, as well as the occupational health services that their own employers provide. And we've also been contacting social care providers, so care homes, domiciliary care providers, hospices, to make sure that their staff are also aware of how they can access the vaccinations, and making sure that our voluntary and community sector partners are also made aware of how their staff can also access the winter vaccinations as well, to make sure they're protected and try and reduce the impact on the system of staff absence due to respiratory illness.
Thank you very much, Lindsay. Okay, I'm going to bring in Jonathan next.
Thank you. I'd just like to focus on number 10 around mental health services with a few questions. Firstly, is there actually a winter surge around people with mental health issues, or is it, like we were talking about before, pressure the whole year round? It sounds from what you were saying like there's a very high amount of pressure. And if there is that focused around particular communities, and do you know which those are, and are you able to tailor the services available to them? Thirdly, we know there have been quite a lot of issues around the new 111 service, and be interesting to know how you're mitigating those as we move into the winter. And the fact that it looks like the service is under so much pressure anyway, it just leaves me a bit worried about what is going to happen if there is a surge.
Thank you. So in terms, is there a winter surge for mental health services? We don't see it in the same way as our colleagues in the acute trust and in community do. We do see generally a peak in activity, usually January time, mid-January-ish, around that time. But generally, it's no more additional pressure in the system than we experience all year round. And as Helen outlined, we have an all year round system in place to help manage that demand. In terms of when we do see surges, are there particular communities? I don't think I can answer that for you today, but what I will do is take that away and provide some information to the chair following this meeting in response to that. I am aware that we have commissioned some additional services through smaller community groups, voluntary-based groups, to support particular population groups throughout the city. So we've had some very good examples of where that's worked, and there's been a very helpful report published by Forum Central about the effectiveness of these grassroots organisations and the support that they've given, particularly to our community services. In relation to your 111 question, I think that's more difficult for me to answer today, because the the commissioning of the 111 system, as you're aware, is a West Yorkshire commissioned organisation. And so it's the West Yorkshire ICB that will be having those discussions about the winter resilience planning with the 111 provider. And we as a system meet and have discussions about, is that support there and is it going to be resilient for us? And as far as we're aware, that is the case, but I don't, as I say, we don't have the detail on that. Maybe Helen can answer that.
Thank you, Alison. I don't have the specific detail on it, and I don't have a representative here today from the Yorkshire Ambulance Service who is our provider of our 111 service across Yorkshire. But having previously worked for that organisation, what I can say is that, you know, they are very robust in terms of resilience. What they do have the ability to do is to bounce those that demand into other services. So 111 is obviously a national service, and between call centres from one region to the next, there is a lot of resilience built around being able to draw on that capacity when one area is peaking over another. The other thing that we undertake is that the 111 service is almost as good as our directory of service. Our directory of service is basically what 111 can access based on somebody describing their symptoms, and can direct them to a number of alternatives besides dispatching an ambulance or recommending that somebody attends an A&E department, which ideally is where we want that to happen if an ambulance or an ED attendance isn't appropriate for that individual. And all services are encouraged in that winter preparedness to actually update their directory of services. So be that alternative provisions for urgent care, it could be for accessing, you know, urgent ophthalmic services in the community, it could be about your primary care services, it could be where, you know, to go with a child with a, you know, respiratory complaint, etc. And we need to make sure that that's up to date, that we have service operating and opening times, how to access that service, etc. So that when those calls go into 111, that they're really well placed to be able to divert those individuals into the most appropriate services. So without a colleague here working directly in there, I think that's the best summary, but I'm more than happy to provide more detailed information if you require it.
Thank you. I'll bring Councillor Venner in.
Yeah, I just wanted to respond to your question, Jonathan, about the summer, about the seasonal mental health surge. So when I was at Leeds Survivor-Led Crisis Service, which is, I left there 6 years ago, so my information might be out of date, but I doubt much has changed really. At that time, like, our service peaks would mirror the NHS LYPFT crisis team. Unsurprisingly, Christmas and New Year was always one of our busiest times. We'd also get the slump in January that Alison described, which sometimes felt like people had held themselves together through a really challenging time of year and then collapsed. We also had a seasonal peak that always really surprised people. I'd be interested to hear if it's still the same in your crisis team, that we had a height summer seasonal peak. And we came to the view that it was because there's aspects of summer that are quite like Christmas, in that services are a bit thin on the ground because staff are on leave. So people might have, you know, people who normally support them who aren't around because they're on holiday. But also the height of summer, I think, like Christmas, can be a time when loneliness and isolation are really magnified. Like, summer's a time when lots of people look like they're having a good time and are going on holiday, and there can be a real sense of discord if you're very depressed and the sun's shining. So if you do a scrutiny meeting about summer preparedness, I think it'd be really interesting to look at whether there is that height of summer seasonal peak, because we certainly experienced that, and I don't know if you still do, Alison, but yeah, us and the crisis team used to tend to be really busy in August, and we thought it was for, yeah, in some ways being quite comparable to Christmas. So that'll be another thing to look at for, yeah, summer preparedness. Thank you.
Thank you, Councillor Venner. Do you have a supplementary, Jonathan?
Thank you. Well, I gave you a good segue into the summer thing there, and I think it would be really interesting to look at that. I think it would be helpful if we could get more information around 111 and the way in which the robustness of that is actually working for Leeds, because although it might be a West Yorkshire contract, that's what our focus is here, and there are some vulnerabilities around that.
Yes, thanks, Jonathan. I agree with you, and I think it's quite it's quite pertinent to understand the process of the directorate service. If there's another region taking our calls in a surge time, do they have all the information specifically again about Leeds? Because we'll be parochial about that on the same as the Leeds Scrutiny Board. So that's fine. Alison, do you want to come back in? Yeah.
Yes, just a point of clarification, Chair. The comments I was making in relation to 111 were in relation to the mental health option, which I've had many a conversation with Health Watch about, not the wider 111 service that is provided by the Yorkshire Ambulance Service.
Yeah, and I think Jonathan's particularly interested in the mental health point, but I think it's an interesting question anyway. Okay, good. I'm going to bring in Councillor Bromley next.
Thank you, Chair. Only last week, a resident got in touch with me because they'd been on the phone for about an hour waiting to get through to the doctor. And so then they gave up and tried to go through the website link, but struggled with the app and etc. So they decided to email me. That seemed to be the easier of the three different options. And I replied in quite a hurry, really worried I was then on an emergency reply to go through to 111, which seemed most straightforward advice in that scenario, as it didn't seem to be an emergency. But in terms of, it struck me as wild that they didn't already know that they could call through to 111, and that wasn't just information that was given while they were on hold to the doctors, especially for an hour. That I think it's quite a length of time. And I just wondered, do we ever put across a template to doctors what would be really helpful overall to have on the answer phone while people are on call, on hold? And also within that, could that not then be tied up with what information is up to date regarding vaccinations, and what to do if you can't get through to somebody to get an appointment, especially if we're talking about the winter surge and elderly members that are probably going to want it to be more of a phone call rather than then going on to an NHS app, and an awareness that you can also pop into the pharmacy as well. Thank you.
Thank you. I noticed that you said earlier you didn't have someone from 111 here, so feel free to answer what you can, but also feel free to say you're right back in due course.
Yeah, again, I don't have a direct primary care colleague here, unless is Lindsay in a position to? Yeah, okay.
Yep, so I'm happy to answer that question. Part of my role within the primary care team is around digital and technology. So we've recently completed a project in Leeds around improving practices' telephony systems so that they're able to provide more information whilst patients are queuing, to change them over to digital telephony systems that allow patients to queue rather than to hear an engaged tone, and choose different options depending on what their needs are. And also quite a lot of our practices have also introduced a functionality called Keep My Place in Queue, where a patient can press the button, hang up the phone, and then the practice will call them back when they reach the front of the queue. So that's improved access across a number of practices. We do encourage practices to think about the messages that they use whilst patients are queuing. They do have control over those messages and can edit them and record them as they see fit. And a number of practices have used, senior GP partners to share messages around how to access services, the different routes into accessing services, and whatever the key kind of campaign messages are at the time. And practices will share information on their websites and social media platforms if they have them around the different routes to access care. So whether that's an online consultation platform or by using the NHS app to either submit requests or to book appointments if they're available.
Thank you very much. You guys follow up?
If we have that fed back to us from residents at times where they say weren't privy to the information that would have been helpful to us in that scenario while waiting for an appointment, who would you advise is then our point of contact? Is it the individual doctor surgery, or is it the sort of NHS provider line?
I just thinking about that as well, Councillor Bromley, and I was thinking maybe we should make a recommendation that we write to the Confederation of Leeds GPs as a scrutiny board. If other members are satisfied with that, saying encouraging them to put voicemail message around 111 around the vaccinations as well. I think that might be helpful. So I don't know if you want to comment on that as well, Lindsay. I'll give you the opportunity, but those were my thoughts.
Yeah, I suppose the two different options would be to either raise it directly with the practice manager to provide feedback on any issues that a patient might be struggling with, or equally you can contact the primary care team at West Yorkshire ICB. We have a dedicated team that supports practices in Leeds, which I'm part of, and we can then support that practice with any particular access issues that patients might be experiencing, and also help them with any communication messages and ways of getting information out there to patients around what the current model of delivering their primary care services happens to be for their practice.
Thank you, Lindsay. So I think there's a casework piece for you, which is your GP practice. But I think for us there is a something around writing to the Confederation, also signposting them back to the ICB if they need support on how to do that. So thanks for that, Lindsay. Okay, I'm going to bring in Councillor Ritchie. Councillor Ritchie's my last on the list. If anyone else wants to talk, do indicate while he's speaking. Thank you.
Thank you, Chair. While writing to the Confederation of GPs, I wonder if it'd be appropriate and helpful to ask if they've circulated the easy read compliments and complaints form that a lot of work went into putting together, because the number of GP practices I've spoken to, the suggestion is not, which is a bit disappointing because a lot of effort went into putting that together with people from lived experience. But actually my main question was around the flu vaccination uptake and the ethnicity split, which I know there's been lots of initiatives to get a more diverse uptake of the vaccination, but the figures are quite stark as to the outside white British and white Irish. Some groups are particularly not taking the vaccine. So I just wondered if we'd actually done a piece of work to find out why is it more hesitancy in those communities? Is it access? Is it the language? The initiatives that we've had in the past not having any effect at all?
I suppose the answer to that question is all of the above. The reasons why people choose not to take up vaccination offer is different depending on the specific community that we might be addressing. So we try and encourage providers to actually look at the particular reasons for a community. We know that some communities have cultural reasons to do with the nasal flu vaccination and the porcine gelatin content of that. So this year we've been encouraging people to make sure that patients are aware of alternatives that are available to them if they don't want to have the nasal flu vaccine. But it depends on the particular group of people that we're working with, and we're trying to learn from that community and address the particular issues, whether that is access around days or times that are more difficult for them, or putting in other measures around trusted messages from community leaders, etc., to try and encourage them to uptake the offer that we're giving to them. But it's an ongoing kind of challenge to deal with, because the reasons are varied and change depending on the particular community group that you're actually working with.
Would you be able to give us a sort of a quick, not necessarily now, but in an email, a quick summary of what the challenges are for each community and what we're doing to tackle them? Because I mean, I don't want to be overly critical, but you'll know that this is sort of a sticky problem, isn't it? Where which is concerning, and I guess there's something about build interest in communities. I think that's really good, and getting good role models. I think that's also really important. So yeah, that'd be quite helpful after the meeting. Councillor Ritchie, do you have a supplementary or follow up on that? No. Okay. Okay. So that's got to the end of the questions. So I just reiterate that we, as a recommendation, we'll write to the Confederation of GPs around trying to get better answer phone messages in while you're waiting for the GP. If you're waiting to phone for appointments, I think that is a good thing that we could write about. Other than that, I think our recommendation is to note the report. So with that, thank you very much for coming. I really appreciate your time. I think it's been really helpful, and thanks for coming, Lindsay, to talk to us about vaccines. That has also been helpful. So thanks for that. And we're going to move on to the work programme. I think guests, you don't have to stay for this bit, but it's a public meeting, so you're very welcome to stay. So okay, so we're going to move on to item 9, which is on page 53, which is the work schedule. Just looking ahead, obviously we've got we are in October, we've got items in November, December, and we've talked a bit about the mental health stuff provision in Leeds in March 2026 as well, earlier in the pre-meeting. Is there anything else, any comments about the work programme or anything else people want to raise about the work programme at this point? Oh yeah, Angela, do you want to just come in?
Yeah, just an update now is in relation to our budget working group meeting. We have now got a date and time of that, which is going to be Tuesday, 16th of December at 11 o'clock. So I will be circulating the invitation after this meeting. Thank you.
Thank you. And as mentioned in the pre-meeting, again, you'll have noted that the adults department is behind on their budget, and they presented to Strategy and Resources. You can go back and watch that if you're interested in the details, but we'll obviously need to be asking questions ourselves in December as well. Okay, any other comments on this work plan? No, great. Okay, so then date and time of the next meeting is Tuesday 18th November at 1:30 back here. Obviously we have a pre-meeting at 1. Thanks everyone for your attendance and participation today. I think we've had an interesting meeting, and I'll see you next time. Thank you.